Good afternoon, everybody. Can everyone in the back hear me okay? Thumbs up. Awesome. All right. My name is Jamie Marco. I am a radiologist over at the NIH Clinical Center right across the way. I'm very happy to be back here speaking with you today. And usually I see a lot of tired faces after lunch, but it looks like you guys are probably good after the swim center this morning. That's great. So you'll laugh at my jokes, which is nice. So what we're going to do today, first of all, I have nothing to disclose. The objectives, really, this should be a talk where you just kind of sit back and enjoy it. We're going to try to determine some parasitic diagnosis using an audience response system. So sometimes it's clickers, but today it's going to be no clickers. It's just going to be, I'm going to get a couple brave people. You look very brave. No, I'm going to get a couple brave people to maybe shoot out what they think the answer could be, just to kind of keep people involved in thinking about the diagnoses. Obviously, no one's being graded or scored or shamed if they get it wrong. And then we're going to review some of the classic imaging appearances of some parasitic infections using different imaging modalities. And then finally, I'm going to try to highlight some things that a radiologist might be thinking of if they see these lesions. Which ones are kind of have a very specific appearance for the type of infection we're going to be talking about, and which ones are a little just more non-specific, and we really would need a suggestion from you that that's what we should be thinking. So, I want to thank Dr. Grant Latin, who used to give this talk maybe about 3 years ago for sharing all the materials. So we're going to go through 10 different cases. 10 different cases, and hopefully show you a decent spectrum of disease by doing so. So let's start off with case number 1. So I'm not sure what your backgrounds are, so I'll just kind of walk you through what we're looking at. So this is an axial image on a CT scan after the administration of contrast. And can you see? Yes. So we can see a big lesion here occupying most of the rectum of the liver. It's relatively low in density. And notice there's some things you might want to think about in the periphery of it. Okay. So based on this picture, what do you think the most likely diagnosis is? Does anybody want to be brave enough to scream out an answer?
It's okay.
All right, perfect. All right. So perfect. This is the classic appearance. So a liver lesion, a cystic lesion, so this is a low density SCT. If I put a density measurement on it, it would be about 20 Hounsfield units, so that's going to be fluid density. And you'll notice that the things I was trying to point to in the periphery of the lesion are little daughter cysts within the overall cystic structure of the lesion. This is the classic appearance of what we're looking for. So they can affect multiple different anatomic sites, but are most commonly found in the liver. Other sites, and many of these I'll show you, are in the lungs, in the spleen, the kidney, in the retroperitoneum, but separate from a specific organ, and affect soft tissues and bones. And there are 2 main organisms, either granulosis or multilocular. The most common one we'll run into is granulosis, and that's what I just showed you. So the cyst itself will consist of an outer pericyst, a middle laminated membrane, and then an inner endocyst, or intergerminal membrane. Now, at imaging, it depends on what modality you use. So here's an example of an ultrasound image. And ultrasound, things that are anticolored or black are things that contain fluid. So this is a cystic lesion, and trust me that we're imaging the liver right now, and it's a large lesion in the liver. Now, hepatic cysts are extremely common. If we saw a cystic lesion in the liver, we'd most likely just call it a hepatic cyst. But if we're very perceptive, we can look for something called the double line sign. So if you notice, there's these 2 arrows here pointing to an outer line and an inner line, and these lines are the outer pericyst and then the inner endocyst. And creating a double line sign is a finding that should be specific for chronic infection within the liver at ultrasound. Now, there's another finding that helps us make this diagnosis at ultrasound, and it's called the snowflake sign or the snow globe sign. So these cysts often will contain added sand. All right, so ultrasound is a nice modality because it's interactive with the patient, right? So I can have the patient laying on the table, I can have the ultrasound probe on top of the liver, on top of the lesion, and I may be able to see some debris or some sand layering within the debris, laying within the cyst. So now you take the patient and have them roll side to side, it kind of agitates that sand up into the cyst fluid, and then it starts to float down like snowflakes would. And it kind of looks like the snowflakes within a snow globe. So I don't have a great example showing you that, but that's something all radiologists can look for at home. So here is another example of a relatively classic appearance at CT. This time we're in the left lobe of the liver, and you see this dominant cystic mass. The maternal cyst is often higher in density than the peripheral daughter cysts are, as you can tell in this case. And here's a nice gross specimen, which nicely correlates with human confinement. Now, sometimes we'll see calcification in the periphery of the lesion. Oftentimes there are these curvilinear calcifications, as we see in this case here. So you'll see curvilinear calcifications along the wall. A lot of times we think calcification kind of means old disease, but when the calcifications are only in the periphery and they're curvilinear like this, you can still have active infection going on. It's really when we move on to this appearance where we have a densely calcified lesion. So both the outer layers and also the endocyst are completely calcified. That's when we know this is old disease. Now we can see a few complications related to hydatid disease. So the main two are rupture and bacterial infection. So rupture, there's 3 different types. You can have a contained rupture, which is the most common type. And that's when the inner membranes rupture, but the outer pericyst still remains intact. You can have a communicating rupture where the cyst ruptures in communication with the biliary system. And then you can have a direct rupture, which depends on where the lesion is located, but it can either rupture into the peritoneal cavity or into the pleural space. And then you can have superinfection, so bacterial infection. So here are some examples of rupture. Okay, so the image on our radiology right here shows a contained rupture. You can see the membrane, the inner membrane is collapsed, has this kind of wavy appearance, and it's separated from the pericyst. So that's a contained rupture. An ultrasound finding that we can see with contained rupture when there's complete detachment of the inner membrane is something called an ultrasound water lily sign, and that's what we see here. Radiologists and pathologists are always trying to come up with descriptors of things. Half the time it's more tricky than helpful, right? So you have to know what a water lily looks like. But this is supposed to be an ultrasound water lily sign of collapsed membranes separating from the pericyst. Now here's an example of a direct rupture. So I'm going to take you through a few images. We're starting kind of high at the level of the liver, and we're going to move down to the pelvis. So notice there's this cystic lesion, left lobe of the liver, a little bit of confusion on the right. Now we move down, we start to see that these cystic lesions surround the liver here, are extending into the left upper quadrant. Continues to go down, all basically the whole left in the abdomen is filled by cystic lesions. Continues to extend inferiorly, all the way down, filling up the pelvis. So this is evidence of a liver lesion that ruptured both the inner membrane, the outer membrane, and spread out into the peritoneal space. Right. So I mentioned that there's a less common subtype of hydatid disease, so multilocularis. This is something that we only very rarely see in imaging, but this is kind of a bad virulent form that occasionally pops up. By less than 5% of the cases we encounter. Instead of having a dominant cystic lesion, which you may or may not have peripheral daughter cysts, instead you have these little alveolar cysts, so little tiny bags of cysts. And oftentimes it starts, they're in the right lobe of the liver in subcapsular location. And when something looks like this is not specific for us. We'd be concerned that this is a cystic tumor, whether it's cystic metastases or cystic primary hepatic lesion. And oftentimes the margin of these lesions is very kind of infiltrated and aggressive. So this would be a tough diagnosis for us to make solely based on small, tiny, aggressive-looking cysts. All right, now this is like a radiology gold mine kind of practice, so I'm just going to show you a bunch more examples really quickly. Things that are either a little less classic because they don't quite show the daughter cyst, or they have the classic appearance but they're in kind of weird locations. So this is an MRI of the liver, CT-rated image. You see a big cystic lesion in the right lobe of the liver. this looks like your standard hepatic cyst. The only clue that we have in this case is that you can see a very skinny peripheral line, which is very low T2 signal intensity, which is something that's not specific for, but we can see with IDAG. Here is another example, cystic lesion. At this time, we have many enhancing peripheral nodules here. Whenever a radiologist sees a cystic lesion that has solid components, you're definitely thinking neoplasm, although infection is in the differential. So this is something we would need your help to make the diagnosis, not something we'd be sure of an issue. Here is an example of that water lily sign where the membranes are pulled away from the pericyst, this time that's CT. This is a pretty good appearance, but it's in a weird location. It's retroperitoneal. You can see the colon shifted forward, the right kidney shifted forward, isolated retroperitoneal lesion. Here is a classic lesion with a peripheral daughter cyst, curvilinear peripheral calcifications as seen here, but this time we're arising from the left kidney. Here's another classic appearance of the curing lesion with daughter cyst, but this time it's isolated to the retroperitoneum at the level of pelvis. Here is a gross specimen where you can see the outer membrane was collapsed, and you see how the fluid-filled daughter cysts have been opened up. One more example here of classic daughter cyst, this time involving the ovary with pathologic proof. And then within the muscle, so these are MRI images. So this is the thigh, the left thigh of the patient. This is a T1 weighted image. You can see that the bone marrow is very bright. These are peripheral daughter cysts. They are low in signal intensity because it's a T1 weighted image. Fluid is low signal intensity on T1 weighted images. And here's the T2 weighted image confirming that they are a fluid intensity. Here is another example involving the bone, but this time it has a much more aggressive appearance. You can see the bone marrow is diffusely infiltrated by this infectious process, with also extension beyond the cortex involved the surrounding soft tissues. If I saw this picture, I think 95% of the time this is going to be a tumor, probably an aggressive sarcoma. You see this in an axial plane from A, we can imagine these being detached membranes floating within the medullary space of the left femur. Here's another example within the pleural space, classic peripheral daughter cyst. Here's another one in the pleural space, this time with the water lily sign. And that is the counterclockwise. So you have seen more imaging examples than probably like 99.9% of radiologists in the whole entire country. All right, so we're not going to hit everyone quite so well. All right, so let's move on to case number 2. So we start off, we have 2 things here. We got a CT on the right, so that's an axial CT image after contrast. And I want you to notice that there are some tubes here. These tubes are mostly fluid density and they contain some gas as well. So you only got a few options for what dilated tubes can be within the liver. And then we have an MRCP image. So this is a very T2 weighted region trying to show fluid containing structures. Here is your gallbladder, here is your duodenum, here is part of your pancreatica, and here is a dilated common bile duct with something kind of long and skinny living in the common bile duct. So based on these findings, what do you think the most likely diagnosis? Beautiful. So I gotta stop you at any kind of information, right? So, what do we see at imaging? Well, so adult worms are commonly found in the jejunum and the ileum. And so these can appear as linear or curvilinear filling defects when you do a small bowel follow-through. So small bowel follow-through basically you have a patient drink a positive contrast agents, an agent that's going to appear white on X-rays. The worm is going to act like a filling defect and it's going to look like an area which is relatively low in density. Occasionally, the worms will also drink the contrast, and now you're kind of doing a small bowel follow-through of the worm while doing a small bowel follow-through of the patient, which is kind of interesting. If you're doing just an X-ray rather than a small bowel follow-through, depending on the burden of disease, you may actually see gastrointestinal obstructions, multiple diarrhea leads to small bowel. Occasionally, these worms can kind of migrate through the bowel, find the sphincter body, end up in the biliary system, as I showed you in this case, and they can lead to biliary dilatation. And then also you can develop a phenomenon where you get these transient airspace capacities in your lungs, and that's something called locked-load pneumonia. Let's look at some examples of this. So this is a small bowel fall fluid, and you can kind of see the spine back here. You can see these are all small bowel loops filled up with a positive contrast agent. And if you look down here, hopefully you can see there's this curvilinear structure here, where the outside is low density, the inside is high density, and the outside is low density again. So this is one of the worms, but filled with contrast in there together. You see another example of that right here. You see another example here. So that's one of the findings that very uncommon, but if we're very lucky, we can see that imaging. Now, sometimes this is a kid here, came in, abdominal pain, big dilated loops of small bowel and stomach. We'd be concerned that this is bowel obstruction. This patient ends up in the OR, and this is what the surgeon finds. It's this huge conglomeration of worms kind of leading to a mechanical obstruction called present bowel dilatation. You imagine the parents think when they see that? All right. Okay, and then here's another example of manifestation of where the worms find a way to migrate back, they find a way to get into the duodenum and find a way into the biliary system. So the image on the right here, this is an ERCP image, and you can see that there's a filling defect right here. Contrast has been injected into the common bile duct. You see filling defect within the dilated common bile duct. Now the findings that, this is another example of an MRCP, where you can see that instead of being low density contrast injected, it's high density fluid within the dilated duct. And then you can see the worm here filling that dilated duct. This case is continue on with the RCP, this intervention to try to relieve the obstruction, and they pulled this out of the patient's common bowel duct. All right. Doing okay so far? So case number 3. I'm still in the GI system. I still have 2 CT images. The image on your radiology right here, this is our liver. You can notice this is kind of a normal density of the liver. These are normal vessels within the liver. But the whole left lobe is very heterogeneous, kind of mixed in density. This is a sagittal image through the left lobe of the liver. You can see the left lobe of the liver is very large. It has a gentle lateralization with the contour of the liver surface. So of these options, what do you think is the most likely diagnosis? All right. Perfect. All right, so you can have a classic finding that we call turtleback liver. And see why, I guess. I think the liver kind of maybe looks like a turtleback. So this is supposed to be classic for schistosomiasis preformicum. But this isn't the only thing that we can encounter with imaging. If the infection is with Manzoni, that typically manifests as multi-organ disease. We can see findings within the liver, within the biliary system, within the small bowel, colon, the lungs, or even in the brain. Another kind of classic radiology thing is if we get pneumonium infection, we can see this classic appearance of calcified bladder and calcified tubular distal ureters. So we're going to run through these. So here is the surgical specimen from that case I showed you. You can see how nicely the surgical path matches up with the CT image. Here is the path through of the disease with that big brain pneumonia. Now, in setting a multi-organ disease, one of the places that can be involved, I mentioned, was the colon. So here's an example where there was infection of the colon. It led to polyposis, so you can kind of edematous nodules. So you can see these polyps here at the gross specimen match up very nicely with these kind of rounded filling defects on this study, which is ovarian. So there's many different granulomatous processes that can involve the bowel. So this is not a specific finding, but it would be compatible in the setting of a suspected infection. And then the colon can be involved in multiple types of infection. But if you're thinking schistosomiasis, think left colon over right colon. So I'll show you another example of why that is later. Now finally, here is a kind of classic radiology one. Here is this cone-in radiograph of the pelvis. You can see this oval structure here. They've had no contrast or anything with just a plain old X-ray, and the periphery of the bladder is diffusely calcified, so you can see it very well imaging. And then you can notice here, these are the ureters, which are also calcified. Now, the classic like radiology boards picture is not only this picture, but then they're cruel, right? They take an area of calcification and they make it absent. And you're supposed to know by looking at this X-ray that not only do they have schistosomatosis infection, but they also have squamous cell carcinoma as a manifestation of their long-standing chronic infection. So that's how cool radiology are. All right, move on to case number 4. So this is another small bowel follow-through. We're taking a look at the region of the jejunum. We're going to zoom in a little bit. So we're focusing on sort of jejunal roots. And if you haven't seen many small bowel follow-through, this one's very abnormal. The folds are too thick, but in addition to having thickened folds, just look at the millions of little tiny dots all over the bowel wall. So there's kind of a micro papillary polyplatinum process going on involving the mucosa of the jejunum. All right, so what do we think the most likely diagnosis of this?
Stambuloid.
Okay, that's one option. Give us another option. She already. Okay, good. So there are 2 possible options, and the answer is your axis. This is an infection that usually involves the small bowel, and the distribution of disease is typically duodenum or jejunum. So it's caused by the protozoan listed here. Now, it can occur as an active infection, but many people harbor the organism in a carrier state, and it's an important cause of diarrhea. Now, the pathology, so humans acquire the infection by ingesting contaminated food or water. The system undergoes exudation and duodenum, and then the organisms reproduce in the upper small bowel. So once they reproduce in the upper small bowel, they're going to attach to the mucosa where they're located, so we're going to do it in jejunum. And this really triggers this acute and then ultimately chronic inflammatory process of the small bowel. So this will depict, or this will cause our imaging findings. So when we look for iridosis, we're going to look for involvement of the duodenum and the jejunum. We're going to look for abnormalities involving the mucosa, and those abnormalities can either be acute findings, such as thickening, or full thickening or wall thickening, distortion of the bowel, and spiking of the folds. That's kind of an acute inflammatory response of the small bowel. We can also see motility changes. So that inflammation of the small bowel will cause angry small bowel, and that's going to cause spasm and irritability. So as the contrast is trying to make it through the small bowel, you'll see a lot of contractions moving the contrast kind of to and fro. And you can also see an increased amount of secretion, which is kind of dilute our area. Let's look at some examples of this. So here's an image from the small bowel follow-through. You can see the stomach, this is the normal appearance of the stomach, coming down to the duodenum. And you can see many areas are not even pacified with contrast. For example, this big space missing right here. And that's because the spastic bowel is just kind of pushing the contrast out. And the small bowel is angry. And then the areas that actually are pacified look very irregular, these spiky folds. So this is a sign of acute inflammation. It's not specific for infection. If someone had radiation to this region, you could see the same exact finding. So anything that's related to acute inflammation is going to cause this type of appearance of the small bowel. Here's another example. This time it's a larger field of view, and you can see the jejunum up here at the top, ileum here at the bottom. Look how nice and smooth everything is and how well pacified all the ileal roots are. But if you look up at the jejunum, much poorer pacification and much more irregular and spiky shape of all the thickened small bowel. Now, that's pretty obvious, right? It's a pretty clear depiction that there's something wrong in the jejunum. Now, if you go to CT, and unfortunately a lot of people will come in and get CT first, unfortunately or fortunately nowadays, but the findings at CT are much more subtle. So If you look here, this is a small bowel loop. This is the beginning of the duodenum or the beginning of the jejunum in the left upper quadrant. There's no inflammation in the fat. All we see is some subtle thickening of the folds of the bowel. So this is something one could easily sneak by a CT scan, even though it's pretty obvious like a small bowel polyp. So if you do a CT, you're still concerned about this diagnosis, and you get a small bowel polyp, you're probably improve the chance of detecting the finding. All right, so you survived 20 plus minutes of me talking about imaging, so you get a terrible joke. All right, so I searched Google trying to find the best parasite jokes I could find, and literally there are none. There's not a single good one ever. So this is what you get. So the doc says, your digestive problems are caused by parasites called Giardia. My high fever are caused by parasites called malpractice. There you go, yeah. All right, yes. So if anyone can find on Google a good parasite joke for the end of this hour and send it to me, I give you something, but I don't know how to give you credit on the next time. All right, so let's move on to case number 5. We're going to go away from the GI system for a little bit. We're going to go into the brain. So this is an MRI image. It's a T1 wave image, and we're through the level of the ventricle. So this guy in the middle is the third ventricle, and notice that there's something here that shouldn't be here in the back of the third ventricle. All right, now I'm kind, so I may have thrown a little hint in these answers. So waving is the best diagnosis. Neurocystic cirrhosis. All right, so cystic cirrhosis can involve infection in the it can affect kind of a bunch of different areas, but the main ones that we run into are soft tissue infections, so in muscle versus CNS infection. In neurocystic cirrhosis, this is going to be the most common parasite that involves the central nervous system. It can cause seizures, and radiologists, we love to classify things. So we classify this based on the anatomic distribution of the cyst. So our 4 types are intraventricular, spinal, external, and parenchymal. So here are some examples. Okay. So intraventricular form. This is a flared image. You can see these are the lateral ventricles here. If you're running the lateral ventricle, you can see that there are cystic structures inside these dilated lateral ventricles. So intraventricular form. Here's our spinal form. You can see multiple cystic lesions here, posterior to the kind of the inferior brain, coming down along the inferior aspect of the cervical spinal cord. And then there's the sternal form. You see these are the basal systems of the brain, and they're filled with all these little tiny cysts. The sternal distribution of neurocystic cirrhosis. Now it gets even more complicated with the parenchymal form. People talk about 4 stages of disease with parenchymal neurocystic cirrhosis. So these 4 stages are vesicular, colloidal, granular nodular, and nodular calcified. Obviously, these kind of details are beyond the scope, but just kind of know that we can try to predict what stage of disease is going on based on a couple things, based on edema pattern and the amount of enhancement. So let me show you a few examples of this. Okay, so here is a contrast-enhanced CT image of the brain with the gross specimen that goes with it. And you can kind of see as we zoom up here that there's a cystic lesion here with an enhancing nodule, which nicely matches up with the finding and gross pathology. This is the vesicular form of disease. Here is the colloidal stage of disease. This is a T1 post-contrast image. This low signal intensity region surrounding this enhancing lesion. This is all the vasogenic edema, so very angry, edematous brain surrounding this new enhancing lesion. This is the colloidal stage of disease.
Can I ask you a quick question, sir?
Yes.
If you go back to that previous image,
yeah.
The brain enhancing lesion, we saw that in toxoplasmosis too, and they were trying to, the differential for that was lymphoma. How do you distinguish between the toxo and system?
So unfortunately, brain enhancing lesions have a pretty broad differential. Like when you're a resident, you study in radiology findings, a magic doctor with carcinoma comes up. So that's everything from metastatic lesions to access to glioblastoma, among many different infectious causes. So the imaging findings of a ring cancer lesion is not specific for it. In a minute, we're going to get into, we're going to talk about other types of infection that can affect the brain. And there is one finding with the pathognomonic, which I'll point out when we get to that. But in general, just a ring enhancing lesion, this thing is about a good differential. So you're kind of stuck with that. So you may end up needing to treat the patient and see if it improves. You may have to sample. Thank you for the question. And then here's the last kind of phase of disease. This is a nodular calcified disease. So we have a lateral X-ray of the skull. You can see these little white dots in the brain. So those are little calcified nodules, and you can see how well they correlate with the CT findings, where we have little calcified nodules within the brain. This patient also has evidence of other findings in the brain, including a cystic lesion here, and a large area of encephalomalacia. Here's another example. So we have a cystic lesion, which is occupying the fourth ventricle. We can see that nicely here on this sagittal T2-weighted MR image. And notice that this is the whole lesion, but there's a smaller rounded low signal intensity lesion within it. So here the patient went to surgery. Here is the intraoperative picture. Here's what they took out, the cystic lesion. They opened up the cystic lesion, and here is that peripheral nodule, which matches up to our low signal intensity focus within the fourth ventricle on this MR image. Here's another example. This is a post-contrast T1 weighted image where we have this complex cystic mass occupying the lateral ventricle. And here's the gross specimen. And then here is a soft tissue form of disease. This is going to be end-stage disease, multiple tiny calcified lesions occupying the soft tissues of both thighs. Case number 6. We're going to stay in the brain. So this is a FLAIR image. So FLAIR imaging is really good for picking up a lot of pathology, but especially highlights things that contain a lot of water, like edema. So I'll tell you that these regions that are right are all diffusely abnormal. So we've got the basal ganglia and the thalami symmetrically involved with abnormal FLAIR signal. Based on our recent discussion of neurocystic sarcosis, it's probably not that. So what do you think the most likely diagnosis? All right, so toxo, when we're imaging toxo, it depends on kind of what the patient population is. The two main ones I think of as a radiologist are the neonatal population, where there's an intramural infection, results in intracranial calcifications, sometimes hydrocephalus and microcephalus. And then I think of the immunocompromised adults, and these create these ring-enhancing lesions, like we mentioned. And they're commonly in the basal ganglia, and many times they're multiple. Now, the finding that we're supposed to be able to look for to say this is toxo over all the other things that are on the differential for a ring-enhancing lesion is this asymmetric target sign. That's fine in theory, but I think it's very difficult to be confident that you're looking at an asymmetric target sign. A main differential in this patient population is going to be CNS involvement. Okay, so here are two images trying to highlight what the findings could be in kind of the best case scenario. So here's our FLAIR image. This is coronal. You can see all this bright vasogenic edema, very angry brain surrounding the stool bud. When we give contrast, the edema now is low signal intensity because it's a T1 weighted image, but we see this peripheral enhancement forming almost a complete ring. But the bullseye is not right in the center, right? So this is supposed to be the asymmetric target sign, with the bullseye shifted off to the side, and this is supposed to be pathognomonic for toxo. Here's another example. This time we have post-contrast CT. This is all vasogenic edema, again, very angry brain around the peripheral enhancing region. Again, this is a little bit off to the side, so we have an asymmetric target sign. This is supposed to be pathognomonic for toxin.
always look like that, unfortunately. Sometimes we have other patterns of disease, such as in this case, where we have small nodules of enhancement all throughout the brain. You can see many of them here. Unfortunately, the patient did not do very well, and with this gross specimen here, we can see all these kind of hemorrhagic areas within the brain. And then this is the path where they detect it. All right, joke number 2. A parasite walks into a bar, the bartender says, "Get out, no parasites are welcome in this bar." And the parasite says, "Well, you're not a parasite." Which joke was worse? The challenge is on. Good joke. I'll go to the next one. All right. Case number 7. Back to the GI system. I'm an abdominal imager. All right. Mostly this is a very minimal. Right? So the contrast was injected through the rectum. We filled kind of the whole rectum and colon backwards to the level of the cecum. And ideally, we filled up the terminal ileum and appendix. Now everything's looking great, except for we get to the cecum. All right, so the regular quadrant, this cecum should be, cecum's like the fattest part, right? Instead, we have this almost cone shape to it, and then the terminal ileum looks way too narrow. So we have some kind of infection process involving the right colon instead of the left colon. So based on those findings, what do you think the best diagnosis is? Great. Okay. So when the infection is involved in the colon, we think about it as early findings, late findings, and then complications. So the early findings usually is going to cecum is going to be a place you can look for to CTD. So greater than 90% of cases will involve the cecum. And then we're going to see standard findings of acute inflammation. So things such as granular mucosa, ulcers, and people spend their whole career describing different shapes of ulcers, all of which you can see with acute inflammation, and you can see acute inflammation with the building different things. So ulceration, think acute inflammation. If we don't have the benefit of contrast, and we're just doing an abdominal radiograph, a sign of acute inflammation that we look for is thumb printing. That is when the posture of the colon just basically looks like a big back thumb and smudged onto the x-ray, which I'll show you in the next one. Now over time, this acute inflammation goes to chronic inflammation, and we think of fibrosis and scarring. So the cecum, instead of being granular or ulcerated or edematous, now becomes scarred down, and we get a very toned appearance of the cecum. You can see lots of the normal folds of the colon. That's going to lead to rigidity, stricturing, and ultimately shortening of the bowel. Now, complications that we try to keep an eye out for are toxic nasal colon, which means differential diagnosis, and perforation, which we would detect by seeing free. So here are examples of the early findings of colonic involvement. The image on the right is again a enema. So you can see that the kind of folds are too thick, and then if you look here, there's these collar button ulcers extending out beyond the expected movement of the colon. These are ulcers into the colonic wall. These are signs of acute inflammation. In the absence of contrast, and we're relying on our radiographs, you can see these guys here. These are like big, chubby thumbs, kind of smushed down on the plain film, looking like edematous folds. Now, we've made it through our acute stage, now we're in chronic disease. Again, scarring fibrosis is really what can kind of give it away. So this is, I think, a very nice example of a cone cecum forming kind of point here. And here's an example of a colonic stricture. This area totally never opens up with time. This is a scarred down stricture colon. Now, the bowel is not the only place that these involved. You can develop an immune abscess within the liver, and that's kind of the most common extraintestinal manifestation. So here are two CT images. This is a coronal image, and here is an axial image. So this coronal image, we see a fluid density lesion. It's just a thin rim of inflammation around it, and then we can see kind of the capsule of the liver has been perforated, and now the infectious gunk is extending beyond the liver into the perihepatic space with the subdiaphragmatic space. There's also an angry pleural space adjacent to the liver with the right pleural effusion. findings at axial imaging. So when we have uneven abscess, the most common in the right lobe of the liver, usually subcapsular. We have a relatively small amount of inflammatory response in the liver around them compared to pyogenic abscess. They usually have extensive central necrosis and hemorrhage. And as you can see in that wonderful picture, this is the kind of stuff which is inside of one of them has been likened to anchovy. Delicious. And then extrahepatic expansion, as I showed you in the CT image, is actually a very common finding. So here is another example. And look at these two cases. And kind of change up the second case. You can see that those cases look pretty similar, right? You have low density lesions within the right lobe of the liver, subcapsular in location, peripheral area of enhancement. One's an amoebic abscess, one's a pyogenic abscess. So our imaging findings are not going to be kind of specific enough to tell the organism. We can hopefully suggest infection over tumor. That's probably going to be about as good as we get in the setting of an abscess. All right, case number 8. Still in the bowel. This is a what study? Small bowel follow through. Okay, we got stomach up here, coming down through duodenum. You can notice that there's all these abnormal loops of bowel. Look at this thing. This is like a ribbon of bowel. It's very narrow. There's no folds to it. This looks like an abnormal ribbon-like loop of bowel compared to the more normal urine bowel right here. Based on those findings and the answer choices I developed, what do you think the best diagnosis is? Yeah, there you go. Unbelievable. Perfect. All right, so like everything I've shown you involving the bowel so far, things kind of follow the same pattern. Where something is causing inflammation, which becomes acute inflammation, and then goes on to chronic inflammation. So this is no different. Okay, so stage 1, we're going to see thickened folds, spastic bowel, irregular appearance of the folds, which means spiky in appearance. Spiky folds, poor opacification due to spasticity, spastic bowel. Over time, inflammation continues, we start to develop malabsorption. You can see many of these folds are still thickened. And then we lead to our chronic findings. So loss of fold pattern, rigidity, narrowing, ribbon-like bowel, scarred down stomach. This is a appearance called laminitis plastica of the stomach. Ribbon-like bowel here. Not only can the small bowel be involved, but the colon can be involved. This is also the acute disease with the polypoid pattern on the gross specimen. Polypoid wall thickening here. Angry bowel leads to ascites adjacent to the angry bowel. This case also had pulmonary manifestations where we had bilateral pneumonias and numerous ground glass nodules throughout the lungs. They had infusion, which was tapped, and it became hemorrhagic effusion. They also had cardiac involvement where they had endomyocardial fibrosis. You can see the wall looks way too thick. There's this low signal stuff filling up the ventricle, not allowing contrast to make it into the normal ventricular cavity. And then here is a gross specimen of an mitral valve. All right. Case number 9. 2 more to go. Now we're shifting. We got X-rays of the knee. We have a frontal radiograph here, a lateral radiograph here. Notice that there is a complete loss of joint space here laterally, so they have lateral compartment arthritis. In addition to that, they have these linear type calcifications within the soft tissues, some of which are fragmented. Based on those findings, what do you think the best diagnosis is? Not a gonococcal therapy.
Ra không? Ra không vừa. Ra không vừa lại.
So what we see here, so this is interesting, right? We get dead worms actually calcify. Right? So if you think, what are they going to look like? They're going to be either serpentine or curvilinear interference. We look at 1 million X-rays a day and we see calcifications which are linear all the time. Let's look at the vascular calcifications. This would be a really kind of weird distribution of vascular calcifications, although they could look similar. Now, why are they fragmented? Well, there's a muscular contraction where you bend your knees to make sure you break them up into little pieces. So we get these fragmented curvilinear calcifications. Now, if there was a joint involved in an infection, it wouldn't be uncommon to either see infusion, which is kind of hard to detect fusions of brain film, but if this area is a little too dense, we can suspect a supracellulary infusion. But the presence of arthritis, especially kind of in weird distribution, lateral compartment with a normal sparing medial compartment, kind of atypical for your normal osteoarthritis. So this is probably a sequelae of an infectious process. All right, last case. This is a esophagram. So we gave contrast through the mouth, took an X-ray image of the esophagus, which our esophagus is usually very, very, very thin in caliber. This is 50 times too big. And then take a look at the GE junction at Clinton. What do we think? Shire disease. So again, as I've been pointing out, all these things can run in a cycle. And our radiologic manifestations depend on the stage of the cycle. So early on, we see dysmotility as the kind of sign of inflammation within the esophagus. Later on, we're going to see signs of scar. And then kind of down the road, what we expect to see is evidence of cardiomyopathy, so we're going to see a big heart, or we can see dilated bowel, commonly either maybe esophagus or maybe a colon. So here are some examples of that. So this is early disease. All we see is dysmotility. When someone swallows contrast, we typically see a primary wave just emptying the whole esophagus in one smooth pattern of all the contrast. If a little bit of contrast is left over, there's a secondary wave which cleans out the rest of the contrast. So we shouldn't see tertiary waves, which are these disorganized waves. And that's exactly what we see here. There's all these kind of disorganized contractions enhancing the lumen of the esophagus. The tertiary contractions indicative of the passage of this esophagus. Now here's an example a little bit later down the line. Now the esophagus is not just showing dysmotility, but it's really dilated. And it's just kind of like a baggy esophagus filled with contrast, with a mega esophagus. Now this is even later stage disease. There's a tight narrowing at the gastroesophageal junction, big baggy esophagus, just kind of storing contrast like a reservoir, and then all this kind of leftover debris sitting within the dilated esophagus. Now over time, having all this stasis in your esophagus is going to lead to angioesophagus, which can form these right here, which are areas of inflammation involved in the wall. Think of ulcerations or plaques. And then over time, as that gets worse and worse, the patient is set up for developing esophageal carcinoma, and that's what happened in this case. Not only did they develop carcinoma, that carcinoma led to a perforation, which we can see posterior here at the blue arrow behind the esophagus. Know that it can affect areas of the bowel beyond the esophagus. So here's an example where the duodenum is too big, which is a negative duodenum. Here's an example of a naked colon. And that is what I have for you today. Does anyone have any questions about any of the cases I showed? Or any comments? No? All right. Well, thank you very much for your attention and participating. the